Sleep disorders. A 35-year-old man was recently hospitalized for the 10th time after he crashed his car into a post. When questioned, he did not remember the cause of the accident and had just had his license suspended. His friends reported occasions when he fell asleep during dinner and during conversations with them. So what we have here is a patient who has narcolepsy. The narcolepsy is characterized by excessive daytime sleepiness and abnormalities of REM for at least a period of greater than 3 months. Narcolepsy has been classified as a REM disorder because you're in REM in less than 10 minutes. So these are patients, of course, who do feel very refreshed upon awakening, and that makes sense because they've actually taken a nap. Narcolepsy has 4 things associated with it. The very first one are the sleep attacks, and that's just where you fall asleep. This, of course, being the most common of all the symptoms, and it occurs in about 80% of the patients. The second thing that you find is cataplexy, which is considered pathognomonic. Now, cataplexy is a sudden loss of muscle tone. So what basically happens is that you have these individuals who, after being startled or having any kind of emotional situation or any loud noise, will immediately fall to the ground. If the episode is short, many of them will remain awake and alert as to what is happening. Now, this, of course, is different from a syncopal episode because syncopal episode patients typically do not have consciousness. They're not awake and they're not alert. Hypnagogic and hypnopompic hallucinations are also frequently seen in narcolepsy, the most common of which will be the hypnagogic hallucinations. Now, hypnagogic hallucinations are hallucinations you experience as you are going to sleep, whereas hypnopompic are the hallucinations you experience when you're waking up from sleep. And the last type of symptom that you typically find in narcolepsy will be the sleep paralysis. So when these individuals wake up in the morning, they will be unable to move their limbs, but only for short periods of time. And of course, these individuals do fall asleep very quickly at night. The treatment of choice for narcolepsy, of course, will be forcing these individuals to take naps when necessary. But ideally, from a pharmacotherapeutic point of view, the treatment of choice will be either A, psychostimulants such as methylphenidate or dextroamphetamine, or number 2, modafinil. Modafinil is sort of like a stimulant, but it's not officially a stimulant. So modafinil is safer than the stimulant in that it is non-addicting. The patients will not be selling it. They will not be abusing these drugs as well. So when given a choice between psychostimulant and modafinil, modafinil should be the treatment of choice for narcolepsy. If cataplexy is found, then of course tricyclic antidepressants are the drug of choice only because tricyclic antidepressants suppress REM. So therefore, by suppressing REM, you suppress cataplexy because they think that cataplexy occurs while the patient is in REM. Sleep apnea. An overweight man reports having difficulties in his marriage because of his snoring at night. During the day, he reports feeling tired. This is typical of sleep apnea. These are the patients who have cessation of breathing for more than 10 seconds, and that is basically what apnea is. What is important about these patients is that they also have a very loud snore followed by a heavy pause. It's considered pathological if the patient has 5 episodes or more an hour, or at least more than 30 during the night. Now, sleep apnea can be dangerous because many of these patients can have more than 300 of these episodes at night. Now, physical and psychiatric symptoms, most of these patients are obese, middle-aged men. Many times these patients also have depressive disorders, and they also complain of daytime sleepiness. When the partners complain of the patient's sleep apnea, what they typically complain of is the partner snoring. Their snoring is so loud that it keeps them up all night, and they also complain of the partners thrashing about in the bed because patients do get very restless. When the patients complain themselves, they complain of headaches, they complain of feeling tired, and they complain, of course, of a dry mouth. The patients don't know that they're snoring, but it's because of this constant restlessness, because they constantly wake up at night, even though the patients are not aware of it. That's why they most frequently complain of feeling tired during the day. And because of the multiple episodes of apnea, these are patients that can have arrhythmia, hypoxemia, pulmonary hypertension, asystole, etc. So eventually death could occur as a result of this disorder. There are three types of sleep apnea: obstructive, central, and mixed. Obstructive apnea usually is due to muscular atony in the oropharynx, the nasal area, the tongue, or even because of tonsillar obstruction. Obstructive sleep apnea is usually the most common. Central sleep apnea is due to a lack of respiratory effort, whereas mixed sleep apnea is usually central at first, but then the airways collapse and it becomes prolonged. Now, the treatment of choice for sleep apnea is usually treat the underlying condition. If it's due to obstructive or weight, then diet and surgery could be the treatments indicated. However, the number one treatment will be continuous positive airway pressure, or CPAP. So this is a device that patients use at bedtime. Part of it is a mask that goes over your face. And what that mask does is that it allows the airways to stay open continuously during the night, so you do not have any episodes of apnea. Insomnia. While studying for an important exam, Michael, a third-year college student, has been unable to sleep for the last several days. At night, he lies awake and imagines himself doing poorly on the exam and failing medical school. During the day, he is tired and frequently falls asleep during his classes. What Michael has is basic insomnia, and dysomnia is characterized a disorder of either A, initiating sleep, or B, maintaining sleep. So it takes you a long time to fall asleep, or you are unable to stay asleep. It's usually associated with anxiety. It can also be due to depression. And if it is due to psychiatric disorders like anxiety and depression, then as you would imagine, women tend to have more of these disorders, so you'd probably find more diagnoses of insomnia in women than you would in men. Other psychiatric disorders could be PTSD, OCD, and even eating disorders. So basically, these are individuals who are going to have problems with their sleep. They're going to not be able to function clearly throughout the day because they're not getting adequate sleep. How do you know when people are tired? They're going to yawn all the time. They're going to complain of being tired. They might be eating a lot, so you might have a lot of eating disorders. So the treatment of choice for people who have insomnia is, first of all, determine if the patient truly has insomnia. Many times patients will tell you, "Doctor, I have insomnia. I wake up at 3 o'clock in the morning." And for most of us, that would be difficulty maintaining sleep. However, what we don't realize is that this patient goes to bed at 7 p.m. So here you have a patient that's sleeping 8 hours, and he is saying that he has insomnia, when in reality, well, all he has to do is go to bed later, and he'll probably wake up later. Once you've clearly identified the patient as having insomnia, then try to go over good sleep hygiene techniques. Make sure the patients don't eat a heavy meal before they go to bed. Make sure they don't drink a lot of fluids. Stay away from alcoholic beverages. Stay away from caffeinated beverages. Make sure the room is dark. Make sure the bed is comfortable. Make sure the temperature is comfortable. And these are the things that could help people go to sleep. If this is not working, you might try a behavioral modification technique called stimulus control, where basically the bed is the stimulus for the insomnia. There's a lot of people who read in bed, watch TV in bed, do their homework in bed, do everything in bed, so when it comes time to sleep, your brain doesn't know what in the world you want. So ideally, that's the person where stimulus control would be most effective. So if that individual is having difficulty sleeping and they want to read, then what you would recommend is go read elsewhere. Go to the living room, go to the dining room, go wherever you want to, but read your book elsewhere. If you feel you're going to go to sleep, then go back into the bedroom and see if this is successful. This is not going to work overnight, but eventually over a few weeks, the brain will finally learn that the bed is basically for sleeping, and every time you go to bed, you will fall asleep. Now, the pharmacotherapeutic route will consist of medications. Your choices will be either benzos or non-benzos. What's the problem with the benzodiazepines like temazepam, like triazolam? The problem is the addiction potential. And because we fear the addiction potential, we would prefer to use the non-benzos such as zolpidem or zaleplom. So zolpidem would probably be the drug of choice over everything given the treatment of insomnia. However, when making you choose between behavioral modifications and medications, you know that behavioral is a better alternative. So the treatment of choice overall is behavioral. And if that is not effective, then of course you would use medications. Now, you want to make sure that these patients do not have medical conditions which would be a cause of insomnia, such as pain, any kind of CNS lesions, any kind of endocrine disorders, normal aging, alcohol, diet, any kind of medications, or any brainstem lesions. Let's review the psychiatric differential diagnoses. We have anxiety, tension, depression, any kind of environmental changes, and of course, any other sleep disorder. Now, parasomnias are sleep disorders associated with the sleep stages. So we have nightmares, night terrors, sleep talking, which is called somniloquy, or sleepwalking, which is called somnambulism. Now, let's review where these disorders occur, because that is important. So nightmares occur in REM. Night terrors occur in stages 3 and 4. Sleep talking, or somniloquy, occurs in all of the stages of sleep, and sleepwalking, or somnambulism, typically occurs in stages 3 and 4 of sleep. Now, as far as the characteristics for these disorders, we know that in nightmares, these are individuals who are having bad dreams. We know that we have the potential to remember our dreams, so there is a memory for the disorder, meaning there is a memory of the bad dream. And everybody has nightmares. The more stress you have nightmares, and of course, more than 0.5% of the population will experience nightmares at some point in their lives. Night terrors, on the other hand, are seen more frequently in children. So these are children who wake up in the middle of the night, panic-stricken, they scream, they cry, and then they go back to bed. The next morning, if you were to ask them what happened, they will have no memory of the event. And that's the distinction between nightmares and night terrors. Nightmares, you do remember. Night terrors, you have no memory whatsoever. Sleep talking, or somniloquy, basically is very common in children. Most of us just say a few words, and it can accompany sleep terrors or sleepwalking. And unfortunately, there's no treatment for sleep talking. Sleepwalking is that individual who goes to sleep in his own bed, he wakes up, and basically he will just go to another part of the house, he will cook a meal, he will clean the room, he will rearrange furniture, and you have to be careful because they do open doors and they do open windows. If you wake up a sleepwalker, then they become very confused, they're disoriented, and they really do not know where they are. You see this more frequently in boys than in girls, and you may find a neurological disorder. And the treatment for these disorders, for nightmares, if you remember, nightmares occurred in REM, and tricyclics usually suppress REM, so tricyclics are the treatment of choice for nightmares. For night terrors, because they occur in stages 3 and 4, if you recall, benzodiazepines suppress stage 4. So the treatment of choice for night terrors would usually be benzodiazepine. There's no treatment for sleep talking or somniloquy, but sleepwalking or somnambulism, because it is occurring in 3-4, therefore you know that benzos may suppress it, so usually benzodiazepines are given to these patients in order to suppress some of their sleepwalking episodes. Question number 1. An overweight man of average height presents to a doctor's office complaining of feeling tired during the day. He has missed several days of work due to this problem. Which of the following is the most likely diagnosis? Is it narcolepsy, insomnia, sleep apnea, normal sleep pattern, or hyposomnia? So here we have overweight man complaining of feeling tired. And the answer for that would be, of course, sleep apnea. Letter C would be the correct choice. If it was his wife complaining of it, then what she would be telling you is that he has loud snoring throughout the night. Question 2. Which of the following is the most likely explanation for a young man suddenly falling down but not losing consciousness? Is it A, syncope, B, cataplexy, C, sleep paralysis, D, medication toxicity, or E, hypotensive episode? The fact that you did not lose consciousness rules out syncope. So the most likely answer here is cataplexy, which is a sudden loss of muscle tone without loss of consciousness. And given that this man has cataplexy, then the individual would be diagnosed with narcolepsy. Question number 3. Which of the following is a treatment of choice for insomnia? A, long-term use of benzos, B, behavioral techniques, C, drinking coffee before bedtime, D, regular exercises before bedtime, or E, frequent naps during the day. Now, we know that long-term use of benzos are not ideal treatment. They're very addicting. They can cause tolerance, withdrawal, etc. So if you use benzos, you shouldn't use them for more than 2 weeks, but that is not the ideal treatment. Drinking coffee before bedtime is not going to help with your insomnia. It's actually going to contribute to insomnia. Exercise before bedtime and naps during the day are also going to interfere with normal sleep. So the correct answer is B, behavioral techniques.